In this video, the MCQs related to these concepts will be discussed with explanation of correct and incorrect options.
Multiple choice question number 1.
A 60-year-old male presents with acute dyspnea and pleuritic chest pain. ECG shows S1, Q3, T3. What is the most likely diagnosis? A. Pulmonary embolism. B. Pneumonia. C. Pneumothorax. D. COPD exacerbation. Or E. Heart failure.
The answer is A, pulmonary embolism. The ECG pattern of S1, Q3, T3, a prominent S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3 is classically associated with acute right heart strain caused by a large embolus obstructing pulmonary arterial flow. Pneumonia may also cause pleuritic pain and dyspnea, but it typically presents with fever, productive cough, and focal consolidation on examination rather than this ECG pattern. Pneumothorax can cause sudden dyspnea and pleuritic pain, yet it shows hyperresonance and absent breath sounds clinically, without producing an S1, Q3, T3 appearance. COPD exacerbation usually causes progressive dyspnea and wheezing, not sudden pleuritic pain or this specific ECG morphology. Heart failure often results in orthopnea, bilateral crepitations, and fluid overload rather than acute pleuritic pain with right heart strain signs.
Multiple choice question number 2.
A 35-year-old female presents with proximal muscle weakness and a heliotrope rash. CK is elevated. What is the most likely diagnosis? A. Dermatomyositis. B. Polymyositis. C. Myasthenia gravis. D. Muscular dystrophy. E. Lambert-Eaton syndrome.
The answer is A. Dermatomyositis is the most likely diagnosis because the combination of proximal muscle weakness, marked elevation of creatine kinase, CK, and the presence of a heliotrope rash is a classic and highly specific clinical pattern. Polymyositis also presents with proximal muscle weakness and elevated CK, but it lacks the hallmark cutaneous manifestations seen in dermatomyositis. Myasthenia gravis typically causes fatigable weakness without muscle enzyme elevation or skin findings, making it unsuitable in this scenario. Muscular dystrophies are genetic, slowly progressive disorders that usually begin earlier in life and do not present with characteristic inflammatory rashes. Lambert-Eaton syndrome is a paraneoplastic or autoimmune neuromuscular junction disorder characterized by autonomic symptoms and hyporeflexia rather than rashes or markedly elevated CK.
Multiple choice question number 3.
A 55-year-old male presents with dyspnea, orthopnea, and edema. Echocardiography shows reduced EF. What is the most likely diagnosis? A. Pulmonary embolism. B. COPD. C. HFrEF. D. Pneumonia. E. Asthma.
Answer is C, heart failure with reduced ejection fraction, HFrEF. The patient presents with classic symptoms of left-sided and right-sided congestion, dyspnea, orthopnea, and peripheral edema. And echocardiography confirms a reduced ejection fraction, which is the defining feature of HFrEF. COPD and asthma typically cause wheezing and airflow limitation without reduced EF. Pulmonary embolism presents with sudden dyspnea and pleuritic pain rather than chronic fluid overload. Pneumonia produces fever, cough, and localized chest findings, but does not reduce EF.
Multiple choice question number 4.
A 35-year-old male presents with sudden hematuria and flank pain. Imaging shows renal mass. What is the most likely diagnosis? A. Renal cell carcinoma. B. Transitional cell carcinoma. C. Wilms tumor. D. Polycystic kidney disease. E. Pyelonephritis.
Answer is A, renal cell carcinoma, RCC. The presentation of sudden hematuria, flank pain, and detection of a renal mass on imaging aligns strongly with the classic triad associated with RCC. Transitional cell carcinoma usually arises from the renal pelvis or bladder and manifests primarily with painless hematuria rather than a solid renal mass on imaging. Wilms tumor is predominantly a childhood malignancy and would be highly unusual in a 35-year-old. Polycystic kidney disease typically presents with bilateral renal enlargement, cysts, hypertension, and progressive kidney dysfunction rather than a discrete mass. Pyelonephritis produces fever, dysuria, and flank tenderness, but does not create a solid renal mass.
Multiple choice question number 5.
A 30-year-old female presents with heat intolerance, palpitations, and exophthalmos. Labs show high T4 and suppressed TSH. What is the most likely diagnosis? A. Subacute thyroiditis. B. Hashimoto's thyroiditis. C. Toxic multinodular goiter. D. Graves' disease. Or E. Pituitary adenoma.
Answer is D, Graves' disease. The patient has heat intolerance, palpitations, and exophthalmos, which are classic manifestations of autoimmune hyperthyroidism. The lab findings of elevated T4 with suppressed TSH confirm primary hyperthyroidism, and among the listed options, only Graves' disease is characteristically associated with exophthalmos due to autoimmune infiltration of orbital tissues. Hashimoto's thyroiditis typically leads to hypothyroidism rather than hyperthyroidism, except for a brief early hyperthyroid phase without eye signs. Toxic multinodular goiter causes hyperthyroidism but does not produce ophthalmopathy. Subacute thyroiditis presents with a painful thyroid and transient hyperthyroidism, again without exophthalmos. Pituitary adenoma causing hyperthyroidism would show elevated TSH, not suppressed levels.